My name is Kevin Terefenko. I am a member of Keystone Orthopedics, and I practice at the Arthritis and Joint Replacement Center of Reading. I'd like to thank Lynn and Paula and the crew of the Joint Care Center for welcoming all of us here tonight and having you. It's a tremendous effort to put this kind of program together. Steve, I'd like to commend Steve for his leadership at the hospital. He just really, truly took you on a whirlwind tour of joint replacement. The material that he covered there, each topic that he touched upon, we as surgeons often come together for 3 or 4 days at a time and debate each of those topics individually. Should we save a ligament? Should we take it? Should we use a drain? Should we not? Should we close with staples? Should we close with subcutaneous sutures? There is so much that goes on in the operating room in these procedures, and we're really chasing perfection with each of these steps. But I think some important things, disclaimers that I'd issue. My professors always taught me that we change something in orthopedics every 3 to 5 years, but it takes us 10 to 15 years to figure out if we did the right thing. And I think that's very true. Just because you see a commercial that for the past two months somebody's been using a new technique, that doesn't mean it's the best way to do surgery. We need case-based evidence over years of time and following patients' outcomes to make sure that we're doing the right thing. And sometimes we make the right decision and sometimes we don't. I'm going to talk specifically about my approach to knee replacement surgery, and for the most part, that's patient-specific custom design. Within the realm of arthritis, there are more than 100 different types, and we generally divide them into 2 major types, the first being wear and tear arthritis or osteoarthritis, and the second being inflammatory types of arthritis, such as rheumatoid disease, lupus, and other members of that group. Most people, the vast majority of people that come in front of us have wear and tear arthritis or osteoarthritis. Some have inflammatory arthritis alone, and some have both. Many patients with rheumatoid disease have a condition where their body is trying to digest their own cartilage, and at the same time, they wear out their joint. What is osteoarthritis? It's a degenerative condition characterized by loss of articular cartilage. In simplest terms, I tell my patients they're wearing away the tread on their tires. Their cartilage begins to disappear, and that can happen in any joint in their body. It's a progressive wear and tear condition, and typically, as Steve alluded to, we are able as surgeons to diagnose it for the most part by taking a very thorough history, using our clinical examination skills, and also looking at plain x-rays taken in the office setting. In a healthy knee, there's a normal articular surface that separates the bone surfaces. There are 2 types of cartilage. There's one type covering the end of the bone, and a second type that acts as the meniscus, or the shock absorber inside the knee. In an arthritic knee, you can see the lesions where the cartilage is actually worn away, and what happens is the bone beneath there begins to see too much stress. It becomes angry and painful, and there's a condition that many refer to as a bone bruise or marrow edema, where there's actually swelling or bleeding or fluid accumulation inside the bone because the bone becomes uncomfortable from the stress that it is seeing. Osteoarthritis, unfortunately, typically affects women much more than men. In my own practice, I probably replace 5 knees in women for every 2 knees that I replace in men. Obesity certainly increases risk. The heavier you are, the more weight that's on your frame, the greater the stress on your cartilage with each step that you take throughout the day. Genetic factors are currently unknown. We know that these diseases are multifactorial. Your weight, your sex, your age, your activity level, your work, there are many, many things that go into determining whether or not you're going to develop arthritis in your lifetime. In addition, many people have terrible arthritis but don't have symptoms. I see people in my office every day that have x-rays where the bone is touching against the bone. I'll be prepared to walk in and talk to them about a knee replacement, but they'll tell me they played 27 holes of golf earlier that day. They're a little stiff, but they feel pretty good. So not everyone with bad x-rays needs to have an operation. What are some of the common symptoms? Joint pain after use, stiffness after inactivity, particularly at rest. You're sitting here, it's tough to stand up from the chair to leave. Limited range of motion. The arthritic patients in my practice, I follow them yearly with respect to their range of motion, and typically they'll lose 2 or 3 or 5 degrees of ability to bend their hip or their knee with each passing year. Many of these joints swell, and there's also a crackling sound that we refer to as crepitus, where the joints can actually begin to make noise. Symptoms may also include pain at rest or at night, instability, where the joint begins to change in its position, and joint deformity. What are our goals of treatment? My primary goal is to maintain joint mobility and function and to limit a patient's pain. I like what I do very much because we're able to restore people's quality of life. We're able to take people that are inactive and enjoyed activities and help them to return to those activities. Briefly, Steve alluded to some of the non-surgical methods of treatment. First and foremost, we try to modify people's lifestyle. There are often certain activities that cause people to have persistent pain. Sometimes we can change their work environment, their home environment, their activity environment, and we can ease their symptoms. Topical therapies are things that can be applied to the skin. I'm very fond of bracing options. Many times I can change alignment of limbs with braces and keep people much more comfortable. There's drug therapy and different types of injections. We'll be happy to answer questions about any of these things at the end. Each of those is a topic unto itself. What are some of the surgical treatment options that we use on a day-to-day basis? Arthroscopy is very common as an early treatment. This is an act of putting a camera into the knee, evaluating the knee on a television screen that's right in front of us, and being able to clean inside the knee or make minor adjustments to the knee. Certainly we can't change the alignment of a limb, and we can't help cartilage to regrow that's been damaged, but we're often able to clean a knee and make patients feel much better. We can also alleviate mechanical symptoms with camera surgery. Osteotomy is a procedure that I did at a very high frequency in my training. It's a procedure where we actually cut the bone, fracture the bone, not all the way through, but we can actually change the alignment, apply plates and screws, and change the force, analogous to changing the alignment of a car. We actually have to break either the thigh bone or the shin bone, but we can keep people away from having a joint replacement by realigning their limb. Unicompartmental replacement is what Steve referred to as a partial knee replacement. Each of us has a very high level of proficiency with that procedure, but it's not commonly done. And I think what's happened when probably 15 years ago, that procedure was forced onto people that were younger, and we found that that wasn't necessarily the right operation for them. We tried to do that operation in more and more patients. There was a very high failure rate, and we've now narrowed down our indications with that operation to a very unique subset of patients. We still do that procedure, but it's done far less frequently than it was years ago. And then finally, total knee replacement is the complete resurfacing of the knee. I'm going to talk about my specific technique for doing that particular procedure. Total knee replacement, as we've alluded to tonight, there will be this year more than 650,000 knee replacements done in the United States. I think one important statistic is that 70% of those knee replacements in the literature are sometimes attributed to surgeons that do 10 or less operations a year. One thing that's terribly important is that you find a surgeon who is highly competent in this procedure, ask them how many operations they do, ask them what their complication rate is, ask them what their experience is with this procedure. Typically in the literature, even at university hospital settings, there's about a 1% risk of infection after knee replacement, and that can be a catastrophic complication. I do have case examples that we can talk about in the discussion if people have specific questions. Anytime that I've spoken about this, people always have questions about infection. The alignment of a knee, 90% of total knee replacement failures are due to misalignment during surgery. I am a surgeon that is highly proficient in redo or revision surgery. I see cases referred to me from far and wide that have not gone well, and folks come to me for an opinion as to how to make their knee work correctly. I tell them first and foremost, the best way for me to make their knee work right was for me to have done it right the first time. It's very difficult to go in after somebody's been in a car accident and change things around. When the frame is bent, the frame is bent. And I can make things better, and I often have great success in doing that. But it's much more difficult for me to do a 3 operation to correct a problem that I could have done right in 50 minutes the first time. Patient-specific alignment may result in better surgical outcomes. In my opinion, the more we can limit this in the operating room, I think the better we'll be as surgeons. Capable surgeons that use conventional techniques are very good in 90% of the cases they do, but certainly there are outliers that are more difficult to realign, to balance, to correct. And I think patient-specific technology is particularly efficient and very good in those particular cases. What is patient-specific technology? It uses your own x-rays and an MRI to design specific surgical instruments unique to you. The way this procedure works in my hands is a patient comes into the office. If they're the right age, activity level, they have the right deformity, I'll discuss this technique. They'll have x-rays taken from their hip to their ankle to actually measure something called the mechanical axis, which is a very important alignment where we look and see how the weight is borne through your knee. We'll use an MRI to custom map the articular surface of the patient's knee, and then we'll use that technology in conjunction with an engineer to come up with a surgical blueprint. And the instruments that I'll use in the operating room are made specifically for that patient and can't be used on anyone else. Custom cutting blocks and guides are manufactured to match your exact anatomy. So the instruments that are opened on the back table that come to me sterile fit like a glove for that particular patient. I actually, at the end of each case, give my patients the blocks that I use in the operating room. They're sterilized. I have the patients take them home, tell them to put them on their bookshelf, because I can't use them in anyone else. I can't even use them in that patient again if they should need surgery at a later date. Patient-specific technology is based off the gold standard of the mechanical axis. And as we talked about, we find the center of rotation of the hip, the center of the ankle, and we draw a straight line from the hip all the way down to the ankle, and we see how that transects the knee. It provides a custom fit that more accurately realigns the knee and more specifically places the knee implant in an appropriate position. The particular technology that I use is called the VISIONAIRE system. There are a number of systems that are on the market. Compared to standard knee replacement, in my hands now today, VISIONAIRE reduces my operating room time. In the beginning, there's certainly a learning curve. As each surgeon learns to do this kind of technology, any of the techniques that Dr. Longenecker alluded to, as we're learning these things, it takes us a little more time to be effective in the operating room. But I believe with each of these steps, as we get better as surgeons, we certainly can cut down on operating room time. Why is that important? Well, first and foremost, there's the burden of Obamacare that sits on my shoulder every single day, and I have to find ways to be more efficient and more cost-effective. The less time that a patient is in the operating room, certainly the less cost there is to the insurance industry. I think most importantly, the less time that a patient is under anesthesia in the operating room, the less risk they have for complications. The longer you're under anesthesia, the greater risk for infection, for blood clots, for blood loss, et cetera, et cetera. I can improve alignment, I can be more specific with sizing, and more importantly, I can be very specific with rotation. While the knee is a hinge joint, there are many, many factors going on as to how we place the implants and rotate the implants, and how the end of your knee catches up to your patella or your kneecap at the end of the procedure. And I think I can be much more accurate with the rotation of my implants as they're placed on the bone than I can with conventional techniques. Custom knee replacement improves alignment and sizing by using computer-generated images of the patient's anatomy to determine the bone cuts. The way this technique works in simplest terms is custom cutting guides come to me that are applied anatomically to the patient's bone. They're pinned into position without me entering the canals of their bone any longer, and I then use those custom-generated guides to actually make the resections that allow for placement of the implants. This eliminates the need to violate the intramedullary canal. In conventional knee replacement, a rod is actually a small hole is drilled in the bone, and a rod goes inside the thigh bone, inside the shin bone, and we actually put custom jigs and align them on the rods that are inside the bone. By not entering the canal any longer with this procedure, I cut down on blood loss, I minimize operative time, I also cut down on certain conditions called fat emboli and other potential complications that can be very difficult for the patients during their recovery. VISIONAIRE technology or custom cutting block technology also reduces sterilization needs because there are far fewer instruments. On the left here is my operating room during conventional knee replacement, and these are all the trays of fancy instruments that I need in order to do the operation. So I have several tables of equipment here that my nurses need to capably hand to me during the procedure. To do custom cutting block technology, this is all that I need. I can do an entire operation with those instruments. So it's far easier on my staff, it's far easier on my operating room, it reduces costs in the hospital setting because there's simply less stuff to wash, less stuff to prepare. In general, we talked earlier, basic steps. We select you as a candidate for this type of procedure. We enter specific information into a database, and we order your MRI and your long limb x-rays. You go to the MRI suite, have your MRI done. There are certain limitations. Steve and I talked earlier about obesity in particular in this community. There are certain patients that we can't get into the MRI scanner to use this technology. But mostly, anyone under the 350 pounds would be a candidate for this procedure. An MRI is generated. It's loaded to a secure website and encrypted, and it's sent to engineers across the country that we work directly with. Those engineers communicate directly back to us via the internet, and I'm essentially sent a surgical blueprint. In my hands today, I explain to patients that much of what went on in the operating room when I was doing this stuff in the past is now done at a computer outside of the operating room. So much of the planning and all the steps that would have normally gone on in the operating room, I'm eliminating, and I'm now doing that at a computer screen rather than standing at the operating room table. So that's certainly going to cut down on the patient's exposure to anesthesia. After all these things are worked on by the engineer, three-dimensional bone models are actually generated that are anatomic. Then the custom cutting blocks are designed that are specific for the patient's anatomical features. True bone defects are absolutely accurate down to a tenth of a millimeter. When I put these blocks on in the operating room now, after a lot of work and a lot of experience with this technique, they fit absolutely perfectly. I'm sent an alignment technique like this on the computer. I actually understand my patient's deformity, their malrotation, all of the pathology that's going on inside their knee before I even walk into the room and make an incision. I'm able to review this, make subtle adjustments. If I don't like the alignment that I see, I can make adjustments with the engineers before any of these cutting blocks are generated. This is a cadaveric specimen. You can see how a cutting block would be applied to the knee. Instead of placing a rod inside the femur, that goes right onto the patient's bone, and it's pinned into place, and much of the surgery is done right through that custom cutting block. Why is this technique special in my hands? Time in the operating room is certainly decreased. Anesthesia time is decreased. In my hands, alignment is much better, and I certainly believe that this will decrease the potential risk of complications. In skilled surgeons' hands, complication rates are very, very low. But if I can change a complication rate in my hands from 1% to 0.5%, that's an enormous difference in my practice. It all adds up at the end of the day. Who benefits? I think patients benefit. I think it's a less invasive procedure. With respect to Steve's comments earlier about minimally invasive surgery, I tell my patients that it doesn't exist. I do surgery through very tiny holes because of my experience. Joint replacement by nature is not minimally invasive. Joint replacement is hammering and chiseling and sawing, and it is vigorous physical labor, and it is invasive at the end of the day. I choose to talk about tissue sparing techniques where we're working through mobile windows, and I tell my patients the size of your incision has nothing to do with the success of your procedure. Whether I do it through a 4-inch incision or an 8-inch incision, at the end of the day, it doesn't matter. Success to me is now having my patients come back to me 12 and 13 years after I started my practice here in town, and having the implant that I placed in 2000 or 2001 still be in place and functioning at a high level. That's success. Success isn't how fast you go back to playing marbles. I think we sometimes are fixated on pushing too hard in joint replacement surgery, and you have one time to get this right. So I think long-term outcomes are really where we need to focus. At the end of the day, in my hands, this has become faster surgery. It leads to less blood loss and less anesthesia use. It has now been approximately 3 years since I transfused a knee replacement patient. With the techniques we're using, we've cut down on blood loss. It is very, very rare that we expose anyone to blood from the blood bank. I do believe there is a faster return to life's activities and a faster and more productive recovery. But again, at the end of the day, when I see my patients at 10 years, they don't remember if they got rid of their cane at 3 weeks or 4 weeks. They don't remember if they went back to work at 6 weeks or 8 weeks. They just remember that they're really happy now playing with their grandchildren. For surgeons, I think this is a more efficient operation. There's far fewer instruments and trays. I do believe it will allow us to have greater accuracy. Part of the reason that that's terribly important in our hands is we are now being forced to take care of patients that are in their early 50s, in their 40s. I even, this week alone, have seen patients that are 33, 34, 35 in front of me asking for a knee replacement or a hip replacement. So because we're taking care of patients that are younger and younger, and our patients are living longer and longer, we have to be better at the surgeries that we perform. I do believe in my hands, I've been doing this now for over 4 years, there certainly is an increase in patient satisfaction because of them having a less traumatic surgery. That's actual block on the end of the thigh bone. These are, perhaps I should have issued a disclaimer, surgical video there. These are the implants that we put in. This is a component that goes on the end of the thigh bone here. That's an oxinium knee. This is a part that goes on the top of the shin bone, and that's an artificial kneecap. One misunderstanding in my office is patients say, well, did you replace my whole kneecap? And the answer is no, we rarely ever do that. Typically when we give you an artificial kneecap, we only resurface the underside 30 or 40% of your kneecap, and when you tap the outside of your skin, you're actually touching your native bone. So we save about 60% of your own kneecap. That's a knee implant at the end of the procedure, done by custom technology, and you can see that's a relatively small incision for knee replacement surgery. How long will these implants last? That's another full weekend debate. On average, I teach my patients that 90% of knee replacements are still in place at 10 years, about 75% at 15 years, and about 50% are still in place at 20 years. Longevity depends on a variety of factors, and I'm sure we can all understand them. The skill of your surgeon, the quality of your operation, your body habitus, your age, your place in life, your gender. There are many things that factor into that. One of the primary causes of knee revision still remains wear, although we've gotten much better with that with the plastic technologies that we've developed. I do believe that accuracy of implant alignment will help us to decrease revisions. As Lynn alluded to earlier, we're going to have an epidemic in joint replacement in about 10 years. There are many more patients coming to joint surgery. Many more will come to revision in the next decade, and there are fewer and fewer surgeons training in joint replacement that are going to be proficient in doing those operations. In summary, most of us will be affected by osteoarthritis. All of us may not necessarily develop symptoms. Symptoms do not always correlate to the extent of the disease. Just because your surgeon or your primary care physician tells you have arthritis, it does not mean you need to have an operation. There's a spectrum of treatment options available aimed at reducing pain and maintaining mobility and function. We do everything we can to keep you out of the operating room. We try to be as conservative as able, for as long as able, put off your need for joint reconstruction as long as possible. But certainly, when your quality of life is impaired, there comes a time that surgery is necessary. Newer technologies are emerging to improve implant longevity, and strategies to maximize implant alignment and minimize bearing surface wear are critical as we move forward. Thanks to Lynn and Paula, Steve, and John for including me in the program. I'm grateful for your attention. Thank you.